So hello everybody and welcome to this session within the PCR eValve course, everything you need to know about a transcatheter valve-in-valve procedure. My name is Prendergast, an interventional cardiologist based in London, and I have great pleasure chairing this session supported by a distinguished and expert faculty. Surgical heart valves have been with us for many decades and have contributed to the longevity and quality of life of hundreds of thousands of patients. In recent years, we've seen a trend away from mechanical valves towards biological or tissue valves associated with significant clinical advantages, largely related to the avoidance of the need for anticoagulation and the reduction in significant bleeding complications, supported, of course, by patient preference for this modality of valve intervention. Nothing in life is perfect, however, and these bioprosthetic valves fail over time, leading to stenosis as a result of pannus, thrombus, or calcification, or regurgitation as a consequence of degeneration, or perhaps as a result of infection in the context of prosthetic valve endocarditis. The period over which these valves degenerate varies, and in this registry of all comers coming forward for valve-in-valve interventions, you can see that some valves fail relatively early, whereas other valves fail relatively late. And of course, not featured in this slide is those valves that do not require a further intervention, which may actually function for a good period longer. One thing is clear, however, that as the number of patients with biological valves increases, and as the cohort of patients with these valves gets older and older as a function of the aging population, the number of patients requiring a valve-in-valve intervention will increase dramatically. Furthermore, as Tavi valves become part of everyday practice, these valves will also inevitably fail over a prolonged period. Set, therefore, for a program which encompasses all of these issues. This program, which is supported by Edwards Life Sciences, will address indications for the procedure, the key anatomical and procedural characteristics and considerations, a live case recording from Oxford provided by Drs. Kharbanda and Dawkins, and specific tips and tricks from Dr. John Webb based in Canada in relation to the patient with a small aortic root and a small surgical bioprosthesis. I hope that you will enjoy the educational content, and I hope that you will contribute to the Q&A via our chat facility. So Tanja, please tell us all about the expanding indications for valve intervention in 2020.
Thank you, Bernard, for the kind introduction. Ladies and gentlemen, these are my conflict of interests. Over the last 20 years, we see a clear shift from mechanical to biological valves. Given the durability of a prosthetic valve of 10 to 15 years, we are going to encounter a significant increase in failed bioprosthetic surgical valves. And then, of course, we have to ask ourselves the question, what do we recommend our patient? To undergo redo surgery or a Tavi in surgical valve? There is already solid evidence on aortic THV in surgical bioprosthesis I would like to share with you within the next few minutes. From the Partner 2 aortic valve-in-valve registry, we have learned that after 5 years, all-cause mortality is numerically only a little bit higher as compared to the intermediate risk cohort of the Partner 2 trial, which is kind of surprising. So this gives us a clear hint that the procedure is safe for our patients. And the hemodynamic improvements achieved in the beginning were sustained over 5 years in the survivors, and structural valve degeneration in the secondly implanted Tavi prosthesis was only 5.9% in the survivors. From a matched comparison of next and early generation balloon expandable valves, we have seen that the SAPIEN 3 valve leads to a significant reduction in paravalvular leakage as compared to the SAPIEN XT. It was also observed that the SAPIEN 3 valve has an improved hemodynamic regarding indexed effective orifice area. When we compare all-cause mortality at 30-day, we see a trend towards lower mortality with the SAPIEN 3. However, in this cohort, it did not reach statistical significance. From a real-world data from the TVT registry, it has been shown that over all risk classes for our patient, there is only a low 30-day mortality rate. So in patients with low risk, the mortality was about 0.9%, where it was 4.3% in patients with a high risk. When we look at all-cause mortality at 1 year, it's pretty surprising that patients with a Tavi valve-in-valve procedure had even lower mortality rates as compared to patients who received a Tavi in a native valve. When we go back and compare redo surgery versus TAVR valve-in-valve with the SAPIEN 3, we can clearly see that major complications, as for example all-cause mortality, disabling stroke, life-threatening bleeding, or permanent pacemaker implantation, these complications are significantly higher as compared to a valve-in-valve procedure with the SAPIEN 3. But we are not only dealing with degenerated aortic bioprosthesis, but also with degenerated bioprosthesis in the mitral position. And here the data is not as solid as for the aortic valve, but I think that the evidence we have is also already pretty reassuring. From the recent publication from the VIVID registry, we have seen that we are shifting towards treating lower risk patients, as you may appreciate from this figure. And when you look at the mortality rates after 4 years, you can clearly see that the survival rate of Tavi valve-in-valve is over 60% over 4 years, which is pretty good for this rather intermediate to high-risk patient collective. And when we compare that with the valve-in-ring procedure, we see that a valve-in-ring procedure results in a significantly lower survival. However, it is still almost 50% in this patient cohort. When we look at the TVT-based registry, which also examined valve-in-valve procedures with the SAPIEN 3 in a mitral position, 1,500 patients with either transeptal or a transapical approach were included. The mean age of the patients was 73 years and the mean STS score was 11.1. When we look at the 30-day outcomes, we see that all-cause mortality was numerically lower with this transeptal approach. However, this did not reach statistical significance. When we look at cardiovascular death, this was definitely significantly lower in the transeptal approach as compared to the transapical approach. And there is also data on 1 year outcome, and here we see also very reassuring for the transeptal approach, pretty low all-cause mortality in this high-risk population of 15.8%, and also significantly lower as compared to the transapical approach. So this data for me is very reassuring that mitral valve-in-valve procedure is highly effective and safe for our patients. So in summary, Aortic valve-in-valve through THV in surgical bioprosthesis appears as a safe alternative to redo surgery with the SAPIEN 3 Tavi prosthesis. And this might not only be an option in patients with high surgical risk, as suggested by our current guidelines, but it might also be suitable for low-risk patients. The transeptal mitral valve-in-valve procedure can be considered an option for most patients with degenerated surgical bioprosthetic valves. And these evidence contributed to grant Edwards SAPIEN 3 with both aortic and mitral valve-in-valve indications in patients at high or greater surgical risks. However, it is crucial to consider the overall individual patient journey, the valve durability, and consequences of repeated procedures, especially when we are treating low risk and younger patients. Thank you so much for your attention.
So Tanja, thank you so much for that fantastic overview. We're now going to turn to Giuseppe Tarantini. And Giuseppe, tell us what really matters.
Thank you for your introduction. So my task today is to discuss THV and THV, what really matter. This is my disclosure. Let's start from here, TVT registry, 300,000 patients included. The green bar, the low-risk patient treated by Tavi in Q1 to 2020 that are, way larger, way higher as a number compared to the previous years. And the second concept is the younger age of the patient treated. Having said that, it is clear that if we treat 70 years old patients, we have to foresee in the sequence, considering a life expectancy of 20 years, a kind of more than one TAV in Tavi. So we need to keep in mind that the concept of TAV in TAV is really concrete in the next future. And actually, I believe that between 2021 and 2025, we can have more data related to the need for TAV in TAV and the feasibility of the TAV in TAV. In the meanwhile, I think we have to share and discuss together 2 points: the feasibility and durability of THV in THV, and the second concept is the risk of coronary obstruction. Actually, we don't have so many data related to the TAV and TAV, and the data actually are not even consistent between registry, because if you look at the radio TAVI registry that include patient of 80 years old with an STS of 7%, as the result that are completely different from the transit registry that include same patients in terms of age and surgical risk, but the numbers, the result are completely different. Let's focus our attention on 30-day mortality, 1.4% against 7%. The stroke rate is 0.7% against 3.5%. So we need more data, but actually on European side it's important to highlight the concept that there is just one prosthesis that has a CE mark approval for the THV and THV, whatever is the access and whatever is the size of the valve that you select. And this is not true for the other global or future contenders. Again, the results are also reassuring for the SAPIEN because the stroke rate is 0%, cardiac mortality 2%, moderate to severe regurgitation 4%, and pacemaker rate is less than 88%. What about the risk of coronary obstruction? Again, this is another very important paper. This has been the focus of the research of my institution in many different papers, and just wanna summarize the result with 2 slides. We have to consider 2 things: the risk plane at VTA, the risk plane, the neo-skirt that you create when you tilt up the leaflets because you perform a TAVI in TAVI, and the VTA is the space between the frame of the prosthesis and the aorta. Actually, you have 2 possibilities: the risk plane that is below the coronary artery, and this is the case of SAPIEN. You have a free access to the coronary artery with the catheter. And other 2 situations when you have a self-expandable valve that stays above the plane of the coronaries. In this case, you might access to the coronary artery in case of Tavi only in case you have a large VTA. Otherwise, it's impossible, the cannulation of the coronary artery. So I will share 3 papers. The same concept, coronary access after Tavi. This is the concept number 1, angio-based forecast. And it is clear that the feasibility with Sapien 3 is 70% of coronary access when the competitor self-expandable is below 20%. The unfeasibility is 20% for the Sapien against 40% for the self-expandable valve. These numbers are consistent when you move from the angio-based to the CT-based forecast. This is the Azim group paper, 76% of impaired coronary access when you use self-expandable valve, and on the contrary is below 30% the impaired access to the coronary when you go with the short valve, Sapien 3 valve. Finally, this is the CT-based data, not the forecast, and the last paper from the Sondergaard group, and again, it's consistent the data that when you select as first valve and you go with the valve in THV with the Sapien, the no interference to coronary access is 33%. And on the contrary, when you look at 2 interfering factors and impossibility of coronary access, you have 91% of tricky access or impossibility to cannulate the coronary artery when you select the valve in valve. So this is my last slides, ladies and gentlemen. It's just to conclude to say that the first cut is the deepest. So the first choice is really very important. So when you have a wrist plane that is above the coronary ostia and you have a very narrow aorta, my suggestion is to select SAVR and then to go with the Tavi in valve. On the contrary, when you have a wrist plane that stays below the coronary ostia or you have a very large aorta, you can select Sapien versus self-expandable valve. But this selection is important because it is important also in terms of what happened in the second intervention. Actually, in the second intervention, when you go for Sapien in Sapien, you have the C mark, you have a clear access to the coronary artery. If you have selected, for instance, core valve, and you decide with the second prosthesis to go with the Sapien in core valve, you have the C mark, but you might have some intermediate risk of impairment of coronary access. You don't have the C mark when you go with the core valve in a Sapien, and on the contrary, if you have selected core valve or other long frame valve and you decide to go with the same long frame valve, you have the highest risk for coronary impairment. Thank you for your attention.
So Giuseppe, thank you for that very practical presentation, which really provides some important educational points for our participants. It was fantastic. We're now going to turn to the case, which was recorded in Oxford by Dr. Kharbanda and Dr. Dawkins. And my understanding that this is a very anatomically challenging procedure, so I hope that you will all enjoy the teaching points that are contained within.
Thank you for asking us to join this session. My name is Sam Dawkins and I'm here with my colleague Raj Kharbanda, and we will be presenting a recorded Tavi in Tavi procedure. Neither of us have any conflicts of interest to declare.
So the case we're going to share with you is an 88-year-old lady in whom we undertook a Tavi some months ago. The first procedure was challenging because of severe aortic tortuosity, and you'll see the CT for that. She has no major comorbidities. She initially had a very good result following her valve intervention, but recently described increasing worsening shortness of breath and had a hospital admission with heart failure requiring intravenous diuretics. You see here this lady's TOE. On the left is the non-color views in long axis and short axis, and on the right is the color flow in those views. You see that there's a jet of aortic regurgitation and it's paravalva. And in the short axis view, you can see that there's been some recoil of the TAVR prosthesis and it's a paravalva regurgitation. Very important is procedure planning. And it's particularly important given this lady's coronary height. The sinus of Valsalva measurements are important to understand what the risk of coronary obstruction is, more specifically. And these measurements are within the ranges that we want in order to undertake the valve-in-valve procedure. But given the valve-in-valve nature of this, we want to be aware of the coronary heights and the risk for coronary obstruction. You see here the CT of the femoral access. There's very little calcification at the actual puncture site or in this distal segment of her arterial tree, and we had no concerns about the vascular access.
So here we have a short axis view of the aorta starting in the LVOT. And as you see us coming into the valve, you can see that it is D-shaped, which explains why this patient has a paravalvular leak. There's a valve shown, a virtual valve shown there, which is in blue, and the skirt was what you saw in red. And as you can see, that's well clear of the coronaries. And in fact, the coronaries are, for the most part, above the virtual valve. Here's a long axis view of the aorta, again illustrating the accurate valve with its crowns. And you can see that the sinuses are large and the coronaries are high. So I am not particularly concerned about coronary obstruction in this case. The real challenge here is the aorta, and you can see the whole aorta in this reconstruction here. You can see that their femorals are relatively disease-free, but the aorta itself is extremely tortuous with a very severe bend in the thoracic aorta and several bends in the arch, which will be a challenge. For this procedure, we've chosen the SAPIEN 3 system. As you saw from the CT, the valve is D-shaped, so I think a balloon expandable valve will be better for circularizing the valve and eliminating the paravalvular leak. The Kharbanda system, we feel, will be probably a good system for navigating really challenging aortic anatomy. So we're going to cross over now to the Oxford Cath Lab to see the procedure.
So our standard setup is sedation, anesthetic-led sedation, local anesthetic, left femoral arterial puncture in this case, right femoral arterial puncture for the access site. And in this case, we've punctured the right femoral vein because the left vein was overlying. This is all done with ultrasound guidance, which we think is crucial. The closure is with proglides, 2 proglides, and this is the E-sheath being delivered over a Lunderquist wire, which is our standard approach. And it really straightens out the vessels. And there were no concerns about vascular access in the femoral segment, but the aorta was more challenging. And you can see that really allows easy delivery of the E-sheath there.
So this is with a pigtail coming up the aorta. You can see that first bend, which we saw on the CT. Here's an aortogram to illustrate that we have some way to go to get to the aortic arch. This is the pigtail traveling up and going around a really impressive bend to come down onto the valve.
So this is the first aortogram. You can see the position of the valve and our landmarks for defining the landing zone for our Tavi valve. So this is a supraannular valve, and we're really trying to land this valve within the existing frame structure.
What landmarks are you looking at for that, Raj?
So there's the upper crowns on this valve, which are the upper marker of the valve, and the lower diamonds are just at the lower end of the LVOT. And that, in terms of where the SAPIEN 3 valve needs to sit, it needs to be just below the lower border of this valve, and the upper segment just needs to be at the level of the upper crowns.
So what you've seen just there was a sweep with the fluoroscopy from RAO to LAO, which is just to confirm for sure that the LV wire is going through the valve and not through the paravalvular leak. That's a really important point. You can also check that on the short axis transthoracic echo. In this case, which is something we often do for very tortuous anatomy, we're using the contralateral pigtail with the Lunderquist just to straighten everything out a little bit and give us a bit more backup. And that's one of the tricks we quite often use in tortuous anatomy. as we're advancing the Kharbanda into the patient, one other consideration is that this anatomy is very tortuous, and we will probably need the full length of the Kharbanda system. So this is a case where you would take off the introducer. So the way you do that is to unscrew the cap of the introducer, and then we usually use a clip like this just to strip the plastic. And that gives you an extra 4 or 5 inches on the Sapien 3 delivery system, just to allow us to get all the way around to the valve, which I think will be important in a patient with this degree of tortuosity. It's often also necessary in very tall patients.
So Sam, as you approach this very tortuous and challenging aorta, what tricks do you think you might adopt that is, available on the Kharbanda delivery system, to just try and ease the passage over this very tortuous path?
Well, I think the key point is that the various bends in this aorta are all in different directions. This is very much a three-dimensional problem. And in that case, what I tend to do is use no flex at all. So what I tend to do is leave the flex off, and the valve will generally follow its way around. It's unusual you have to do that for a Tavi. You do quite often have to do that in mitral cases. But using no flex at all was our strategy here. And essentially what you do is use back tension on the LV wire, and we go back and check the pigtail position from time to time, and then just follow around the arch. And as you see, it's really pretty amazing anatomy.
Yeah.
Now, a problem we had here is that the valve catches on the outer edge of the existing valve and wouldn't go any further forward. So what I'm doing here is just pushing the pusher alone to get the valve to go to the right position, which is not something you have to do very often, but is a useful trick if you're struggling to cross the valve. With any valve-in-valve procedure, it's really important that the communication in the cath lab is very clear, so everyone understands about the rapid pacing, and that the rapid pacing run will be a bit longer than usual because we don't want the pacing to come off until the balloon is completely down. The other thing to be very careful about is to make sure that there's no parallax. So in this case, there is a little bit, and what we're going to do is just, you can see there's parallax on the S3 there. What we're going to do now is do a fluoro and add some caudal. And as we do that, you'll see that the parallax disappears.
Yeah. So as we were discussing, the positioning for any valve-in-valve procedure is so important, and you need to understand where you want the new prosthesis to be in relation to the old one. This it looks absolutely perfect, doesn't it? That looks like a really good valve position. The sealing ring of the S3 should accommodate the lower end of this valve, and the balloon expandable nature of this valve should help to circularize the recoiled prosthesis that was in before.
So we're coming up to the valve deployment now. So we are going to rapid pace. Then we're just going to confirm on the arterial trace that the pressure has reduced. And once we're comfortable with that, the valve is going up. You can see that it rides up a little bit, but the valve position looks good here.
So that's excellent, but we're not out of the woods yet. We've got to get the delivery system out now, haven't you? So talk us through what you're going to do there, Sam.
Not rush is the answer. So what we're going to do is shorten the wire in the left ventricle just to try and get the balloon off the outer curve. And so we're just very, very gently coming back. And once the nose cone is past the valve, we can then push the wire and then get the delivery system out. But it's worth taking this very, very gently because you want to lift the edge of the valve as you come around the corner.
Yeah.
And then there was no flex on in the first place, so we're just going to pull all the way out, the delivery system all the way out.
So the assessment of paravalva regurgitation with valves, you really need a proper aortogram and even echo if you need that.
So here's the final aortogram showing a very good valve height with the S3. It also quite nicely illustrates the really impressive aortic anatomy in the descending aorta. There's good flow down both coronaries. You can see the valve is well below, and there is no paravalvular leak. So this is an excellent result that we are very, very pleased with the outcome.
Thank you very much. So that was a valve-in-valve Tavi performed with the Sapien 3 using a Commander delivery system in a very, very tortuous aorta.
So that was fantastic. Thank you to our speakers, and thank you also to Sam and Raj for providing us with such a stimulating and challenging case from Oxford. I'm joined now by the speakers you've heard from already, and also by John Webb, who will be speaking after this intermediate discussion, as it were. And I want to remind you before we launch into our own conversation that the chat facility is available, and we will do our very best to convey the questions through the chat line through me, with the magic of WhatsApp in this particular situation, and we'll see if we can address those questions for you. So firstly, I want to focus on the case, because that's probably freshest in our minds. And Sam, congratulations firstly to you and Adrian for such a wonderful result in a challenging patient. I wasn't sure whether to describe it as an S-shaped aorta, a Z-shaped, or some letter that isn't even in the alphabet, but certainly it was very, very challenging. But maybe Giuseppe and followed by John, have you got any additional points which might have even enhanced the procedure any further with the wisdom of hindsight and observation? Giuseppe.
Thank you, thank you. I think that with this valve, you have a double option to consider if you don't feel comfortable to go transfemoral for this very complex case, to go transapical, for instance. And this is very important because when you have a so severe tortuosity of the valve, you might go from another access that might be more easy for the common interventional cardiologist. And the second point is that what I saw is that the valve, the first valve was seated very asymmetric. So we cannot exclude in this case also kind of, concealed bicuspidity, acquired tricuspid bicuspidity, because after the second valve, what is interesting is to see that with the angio, you have a clear, visualization of the left coronary, left stem that usually, is visible for the kind of bicuspidity valve. But anyway, I think the first point is to congratulate the operator for this challenging case and to consider that we have two options with this valve system. It is Sapien 3 or ultra valve.
So quickly, Sam, did you consider non-transfemoral?
We did. The index procedure was certainly lodged in our memory, so it was something that we did think about. She didn't have an auxiliary option because she had very calcified and tortuous vessels, and she was at the frailer end of the spectrum, and apical or direct aortic, it's a big surgical procedure, and I think for her that would have been a challenge. We've managed this before, and I think with a case like this, you can always stop. And I think we felt that it was worth trying. Her femoral anatomy was pretty straightforward. We were comfortable we could get out of that relatively easily. And if we hadn't been able to advance the valve, we could have stopped and then reconsidered our options. But I think for her, transfemoral was probably the better option.
Okay, and John, transcarotid, and would that be an option? And what other suggestions might you have in hindsight?
Well, I think that there's many options now for alternative access, but to be honest, I think this case could be done femorally, and your operators did a very nice job. A couple of tricks, I would say. First of all, if you have a very tortuous or long aorta, you've got to use a really stiff wire, and they did that nicely with the Lunderquist, which is a really nice wire for this sort of thing. The other thing you can do is put your E-sheath in all the way, not leave it out a little bit. You can remove the loader, but in fact, these days, the loader can be introduced almost entirely into the sheath, so you don't really gain so much out of that anymore. You can mount the stent a little bit distally on the balloon is the other thing. But I think the most important thing is just take your time. and with time, you'll do well. I have one question, though. This was very eccentric in the annulus, and I wonder, had post-dilatation be tried? Often we'll bring people back for post-dilatation late. And I think often people don't consider that even months after a Tavi procedure. The concern might be with stroke if there's embolus on the valve. But in fact, we've never seen this with many late dilatations.
So I think we did consider that. And whenever we have a patient come back with a early failure of a TAVR valve, CT is mandatory to understand the etiology of that. In this patient's case, She had done initially very well, and from the post-procedure TTE, she'd had no paravalvular aortic regurgitation, so we knew that it was late recoil. The CT is then very useful to confirm, firstly, the shape of the valve itself, and secondly, whether there's any calcium behind the area that's recoiled, because you want to be a little careful of post-dilating if it's calcium that was the issue. And in this patient's case, there wasn't. We have tried post-dilating in this situation before, but generally speaking, if they recoil once, they recoil again. And our feeling is valve in valve is the definitive solution. So we have done that before with this mechanism of valve failure, but our experience is that recoil happens again. And actually, just to get the patient out of trouble and out of hospital, it's often better just to do a valve in valve Tavi.
So Sam, two very quick questions from our participants. Number one, did you consider using TOE to improve the safety of the procedure and guide it? And secondly, do you have any data on the residual gradient across the two prostheses?
Yes, we always have TOE as an option. Obviously that in our centre would require a general anaesthetic. We tend to use a TOE almost exclusively now for cases where there's a real difficulty with landmarks. So not so long ago, we did some homograph cases or lab core cases where there really isn't very much to see, in which case a TOE is very useful. In this case, we were pretty comfortable with the landmarks, and we could cross-reference on the CT the index valve with the landmark. So in this case, we didn't feel that TOE was necessary. And the second question about the gradient, the mean gradient just after the procedure was 8 or 9, I think, from memory.
So very good hemodynamic performance, which is very comforting and good for the long term, of course. So I hope that Tanja is with us. I can't see her on the screen, but if she isn't able to join us and can't take this question, perhaps one of you could pick it up. But do you think we should be using a more sophisticated analysis of our pre-TAVI CT to determine the future feasibility of coronary access? Do we need to do more than just measure the coronary height, in other words? Tanja, I'll give you first refusal on that question. But if you're not with us, then perhaps Giuseppe or John could take a stab at it.
Yes, so this is a very important question. I think that making a forecast of coronary engagement in case of TAVI and TAVI is really important, because we have to select the right valve in the right patients when we look at the sequence of the patient, especially when you have a younger patient, you foresee 20 years of life expectancy, you have to foresee at least one TAVI in TAVI. You have to take into account, the importance of the choice of the first valve. I don't think it's enough to look at the height of the valve, because as I've shown during my presentation, what is important is also to look at the width of the sinotubular junction, because when you tilt up the leaflets of the first valve, when you go with the second TAVI in TAVI, you create a kind of covered stent. So in that case, it's going to be very difficult. Even though if you go with the short valve that is sapien within a tall valve, you might have some problem to engage the coronary artery. So in that case, it's better looking at the forecast to choose a short valve like the Ultra to avoid to have a really bad surprise in this regard.
Any additional comments, John, before you revert to the video?
I think this is incredibly important. I think in the future, when we're doing patients that are going to have longevities over, say, 10 years, it'll be incumbent on us to know that when we put a TAVI valve in, that this is going to be a repeatable process. And I see all sorts of cases where that isn't going to be the case. This case, for instance, the coronaries are going to be very difficult to access now. That may or may not be important to this individual. If there were a smaller sinotubular junction, the leaflets really go quite high with the accurate valve. And I think that coronary sequestration would be a serious issue in many patients. And it's been an issue in some of the patients we've had with late failure of accurate valves is they're concerning as to whether they'll be candidates for redo.
Okay, fantastic. So let's return now to John's lecture, and then we'll come back together as a group for a final discussion. So we're now moving away from the field of TAVI in TAVI valve-in-valve procedures and back towards the field of intervention for failing surgical valves. And our final speaker is John Webb from Canada, who's going to provide us his own personal tips and tricks for this challenging subset of patients.
Okay, thank you very much. I'm John Webb, and I'm going to talk about some tips and tricks for valve implantation in small valve prosthesis with an expandable valve. So there's my obvious disclosure. Now, we have a long history with the sapien type valves and valve implants. This is a 3-year report that we did of the partner registry showing excellent reduction in gradients and virtually no aortic insufficiency, and importantly, dramatic improvement in function of, and quality of life, durable up to 3 years here. Now we have a 5-year data now just presented at TCT. So it's a good durable solution, but we learned a lot about how to do this. First of all, in the early days at the bottom right, that's how we often implanted these sapien valves, was 50-50 within the surgical valve. We found out that yes, that's very good anchoring, and sizing becomes less important in terms of actually getting the valve in, but it's much better to implant the valve high. There on the left, you can see there's better opening of the leaflets and lower gradients. So here's an example of how we would implant one of these valves today. Take a look at the top of the valve where we want it to end up above the top of the surgical valve post, and we try and have the inflow of the TAVI valve just at the inflow of the surgical valve for optimization of leaflet function. And particularly when we're treating small valves, like for instance, here's a 21 mitral flow with an ID of around 16. There you can see we've implanted a fully expanded sapien 3 20 millimeter valve just above the ring, still rigidly held by the struts and the gradient to 13 millimeters, which I think is quite acceptable for a small valve like that. Now, I think when you do see high gradients in small surgical valves after a valve, you have to be a little cautious because of the problem of pressure recovery and estimation of Bernoulli gradients with in different types of valves. And it's pretty clear that some types of valves, for instance, intraannular valves, have a falsely high gradient by echo. And that's more evident in valves that are functioning relatively well. If you have a tight stenosis, that's reliable. If you have just a moderate stenosis, then echo may be a little bit unreliable, particularly in tubular short valves. And here's an example of the next generation sapien valve, which I can't show you, that's why it's covered up there. But there you can see we have an echo mean gradient of 15 millimeters of mercury with this 20 millimeter valve, but we do an invasive gradient, and there you can see, in fact, it's only 4, and that's actually very, very common. You might want to think about that before you consider cracking, which is what I'm going to talk about here briefly. There's the setup that we like to use in Vancouver. We use a small and a large atrium syringe. The large atrium can be buttressed right on the bed, and we've got a stopcock, which is actually forced over the wrong way, so we get continuous pressure from the manometer there without having to switch hands or switch the stopcock. Takes that an extra step. You always have to use a very non-compliant balloon. The best one going probably is the true balloon at this time, and here you can see we're actually cracking a mitral flow valve. It's just going to crack. If you have audio, you might actually even hear that. We typically take a balloon that's larger than the ID, and ideally the same diameter as the valve you're going to implant. There's an example of a cracked Paramount type valve with a sapien 3 valve inside it. Now, we can even remodel valves we can't crack. So for instance, here's a trifecta, 21 millimeter gradient after a valve and valve implant. After cracking, we actually haven't broken the trifecta titanium ring, but we have stretched the posts out and gotten a reduction gradient to 10. You shouldn't think that you can't crack almost anybody to some degree. Well, now, you can do this early or late. Here's a patient that had an underdeployed sapien 3 inside a mosaic valve, and here we came back several months later and post-dilated the 23 millimeter valve with the 23 millimeter balloon and got an excellent hemodynamic result. Now, when to crack, before or after valve implantation? Well, the argument for cracking before is that you're less likely maybe to damage the TAVI valve leaflets. There may be the other argument for cracking later is that, you know, if you crack early, you may actually tear the leaflets and get severe insufficiency. And there you can see that generally fracture after tends to get lower gradients because you get more full and complete expansion of the TAVI valve. with high pressure dilatation and cracking at the same time. Here's an example of a patient where we cracked first and then put in the Tavi valve. And there you can see we actually dehisced the leaflet and ended up having to do CPR for 2.5 minutes until the final valve ends. So we're strong adherents to cracking after the Tavi valve is put in, unless there's some extenuating circumstances. Now we get dramatic reductions in gradient. Here you can see with the 23 mitral flow, progressively we post-dilated from 18, where it was originally, up to 23 millimeters, which it should be, with a dramatic reduction in gradient. And this is the sort of thing you're going to see with this. Now, so which valve should we crack? Well, generally we do this routinely if there's an elevated gradient that we're concerned about. But often if the valve just appears very expanded on fluoroscopy, and it is speculative, but many people would routinely crack these days to improve leaflet function, durability, and reduce thrombosis. I guess we need some more studies before we can recommend that. Here's an angiographic view to help you determine the risk of left main occlusion. We go to eleocrania, we get parallel or perpendicular to the valve plane and line up the two posts either side of the coronary os. And that's very useful, I think. You can do the same thing, even with, say, a mosaic flow, where you can see we've lined up the two posts on the right screen. And we have a very nice view of the left main to see if that's a concern. But CT is the gold standard, I think. We like to see low risk of occlusion, the sinotubular junction sequestration, and also the leaflets. And that is something you just routinely need to be aware of. And if you get too aggressive, this is what's going to happen. Here's one of our patients. No flow to the left main coronary artery. The heart is basically akinetic. And with rapid stenting and ECMO support, there you can see we've got nice flow and return of normal function. That patient actually was discharged 2 days later. So you certainly, although valve-in-valve procedures are associated with an increased risk of coronary occlusion, you have to be very careful about it. You can treat these, but I wouldn't want you to think that. So that was a patient that was salvaged from left coronary obstruction, but I don't think you should think that chimney stenting for left main obstruction is necessarily a great outcome for your patients. Here's an example of another patient that had chimney stenting on the left, and here afterwards they're stable with good flow into the left coronary artery, but there you can see it 1 year later, there's restenosis around the osseous left main coronary artery. So I think of this as a way to salvage patient where you've occluded the coronary, but not necessarily guaranteeing them a long-term good solution. I think they need follow-up when they have this sort of thing done. Now, in future, I think that the coronaries are going to become increasingly important, even more than they have been with surgical valves, with transcatheter valves. And here's an example of a patient that had a transcatheter valve implantation transapically over a decade ago, came back with restenosis, and this time had a transfemoral sapien 3 inside a sapien valve. And there you can see the gradient again is 14 millimeters of mercury, an excellent result. With this, the left main coronary artery is still free. And I think that you're going to more and more find that this is an issue with many transcatheter valves, that repeat TAVR may be an issue due to supraannular leaflets or struts in the region of the coronary arteries. And that'll be the future for us. We'll have to evaluate these patients in advance for these sorts of concerns. Thank you very much, John.
Thanks, John. So we'll take those practical points away to our cath labs in the coming weeks and months. And now let's focus on some of the issues that you raised with our panel.
So thanks very much again, John. So it was a great talk, as always. And I concur absolutely with your comments about valve cracking and whether you should crack before or after implantation of your second device. I remember vividly the first 2 cases that we cracked before implantation, and both of them had severe aortic regurgitation and needed on-table resuscitation. And we learned bitterly from those experiences. But one of the reasons we'd gone with that strategy was the discussion about potential for harm to the newly implanted Tavi leaflets when you're using a true balloon or a gold balloon. Does the excessive trauma with very high barometric pressures somehow influence leaflet morphology or durability? It's speculative, but do you have views on that?
I think that it is a possibility that there might be some minor trauma to the leaflets, and that might lead to earlier restenosis, but we haven't actually seen that. And even in vitro studies have shown that the injury to the leaflets appears to be relatively minor. So I don't think this is going to be a major concern. I think that the bigger concern may be, for instance, with some supraannular valves, for instance, the evolute, which has a constrained mid-zone. if you dilate that after implantation with the big balloon, you may tear those leaflets. And in Canada, I assume in Europe as well, there's recently an announcement by Medtronic about that, saying, not to overdilate their valves with larger balloons. And the waist, of course, is around 22 to 24 millimeters with that valve, regardless of size. So in those cases, you may want to, dilate first if you're going to need a bigger balloon to do that.
Practical question I wanted to ask you, John, was that graphic image that you had of the late thrombosis of the chimney stent. What's your antithrombotic or anticoagulant regime for these patients with a TAVI and a stent in the left main stem coronary?
I don't think that was thrombus. That was just, I think, partial collapse of the stent in the left main. And but we routinely have people on, routinely with TAVI on single antiplatelet therapy in our setting. With valve and valves, we almost always have people on full anticoagulation. And then with a stent, we'd probably have them on antiplatelet agents for at least a year.
Okay, and just to clarify, by full anticoagulation, you mean warfarin or a new oral anticoagulant? A NOAC?
Yes, that's right.
Exactly.
That's right.
Thank you.
I think we know that there's an increased risk of thrombus with valve and valve, and I suspect that's also applicable to TAVI and TAVI.
Excuse me, Benny.
Okay, so go Giuseppe, go.
Yes, I think that's, this point is really remarkable, but looking at the whole picture, I think this is the major role also of the heart team. Because when we discuss a patient with severe aortic stenosis that is younger, for instance, it is important to increase the awareness also in the surgeons that the first valve that they choose for that patients matter in terms of the next option that the patient will have in terms of transcatheter approach. So what is important is probably to avoid these externally mounted leaflets or sutureless valve or other things that might compromise or, can get the things more difficult when we decide to, to complete the sequence, to treat again the patient by a transcatheter approach. We don't want to have this kind of problem. So one way to go is to avoid thinking the needle cracking and to decide the right surgical valve from the very early attempt, from the very early beginning.
No, you're absolutely right, Giuseppe. I mean, all of this is about collaboration, isn't it? It's about making the right choice at the beginning and then making the right choices over subsequent follow-up. So Giuseppe, I want to ask you a very practical question for everybody joining us. What are your top 3 tips for doing PCI in patients with a pre-existing TAVI device?
Okay, I think we have 3 things to do. The first one is to check with the not only by CT scan, but also with the angio, with the catheter, to understand if it is possible to fully engage the coronary artery. This is very important because if you get through the, if you can get in the coronary, going through the top part of the leaflets, that means above the wrist plane, you won't have any problem also to engage the coronary also with the second TAV in TAV. Another trick is that you don't have to think like a native coronary artery in a patient without any prosthesis, because the right choice is to select, for me, the normal Dawkins catheter and to think going into the coronary from top down, and not tilting up the catheter like with the XB or the other catheter. And actually, it is very rare to have the need to use extra backup or very complex CTO technique to get through the coronary when you take care of these 2 points that I told you before.
Okay, any additional comments, Sam and John? Technical tips for our colleagues?
So I think you want to start
using a Judkins catheter, JL catheter particularly, is often the very best for getting into the left coronary, which is not what any of us would usually use for PCI in the left coronary generally, but they tend to work very well.
John?
Yeah, I find Judkins is often the best, and I think one little tip is to go to a view that shows the ostium of the coronary very well. For instance, iliocranial is going to show you the ostium of the left main, and you can just slide down the inner curvature and get underneath the leaflets, which actually with an accurate is not all that easy to do. You know, there's quite a lot of material in between you and the coronary with accurate with the stabilization arches. Even in this case we just saw, we weren't, I don't think, 100% sure. We might have been underneath one of the stabilization arches, and I think it'd be very possible never to know that, but it might be possible to catch on that.
Another point probably, Bernie, is that we have to admit also that, again, for the coronary cannulation, not all the valves are the same, because when you go with a supraannular valve, you have an asymmetric skirt. So it would be nice to orientate this valve, but it's tricky to do that, because if you're unlucky, you go with the, tall skirt in front of the left main, is going to be very, very difficult to cannulate, whatever is the technique that you use to cannulate the coronary artery.
It does seem likely that the next generation of TAVI valves may well have the facility to orient with the coronary arteries. And I mean, there are some valves already, like the Endocarditis valve, for example, where you line up the valve with the cusps.
So yes, Sam, I just want to come to you.
Sometimes helpful in terms of preventing left coronary obstruction. For instance, the Yenna valve and the J valve, both of which clip the left leaflet away from the coronary to some degree.
So we've just got about 1.5 minutes left, guys. So Sam, a very quick comment about patient journey and lifelong journey and the sequence of interventions. You're the youngest on the panel this evening. So is it TAVI first, TAVI, SAVR, TAVI? Is it SAVR, TAVI, TAVI? What is it in your view?
Actually, Bernard, you read my mind. That was exactly the point I was going to make. It's a really good question, and this comes up in our heart team often. If the surgeons are not going to offer a mechanical valve, then why not do the TAVR first? Why not do TAVR first, then do a SAVR in 10 years' time, and then you're doing a valve-in-valve TAVR with one valve rather than two? And currently, that's not what we do. I think our feeling is we should do what is the standard now, because we don't know what valves will be available for us in 10 years' time. But I think it's a pretty compelling argument to do the TAVI first if the surgeons are not going to be offering a mechanical valve.
Fantastic. Well, I'm going to conclude there. We've got 30 seconds to go. I want to thank everybody for contributing in the recordings that we made, for the three of you for joining us for discussion this evening. I think we've provided a technical overview of the issues that are prevalent in relation to TAV-in-TAV and valve-in-valve TAVI. I think we've looked at the promising results from the observational data, and I think we've provided some very practical points for our colleagues. So thank you very much for joining us.
Thank you.